call it. Okay. So guys, just to recap on what we were looking at, we were just showing some information from Cairns and Hinterland. So at the moment we've got influenza circulating and we are about 4 to 5 times the amount of cases that we would normally see for this time of year. We would normally expect to have influenza in far north Queensland at this time of year, and we usually have a secondary seasonal peak around August, September. Some of the other interesting info that we were able to look at when we were looking at the data is that the age range for the cases were quite high in the under 10s and also the over 65s. And then we also checked out whether there was anything with gender. And sorry gents in the room, the grubby boys under 10 seem to take away a fair few cases in that age range. And then there's a large discrepancy in the 20 to 45-year-old women over men. So looking at them being the carers of the under 10 group and possibly being pregnant and things like that, which is important to take into consideration as well. What else do we go? Is that recap? I can hear somebody's dinner plates being scratched. If you can mute, please. And then looking at vaccine hesitancy, so, the majority of the population are quite accepting of vaccination. And then there's about 20%, and sometimes, depending on where you're located, a little bit more than that aren't against vaccination, but they may need persuasion or a confident vaccine service provider to be able to talk to them about their situation and their thoughts around things, but they can be persuaded. And then there's the anti-vaxxers that won't budge no matter what you do. And the biggest thing is that flu vaccine is your best shot at stopping influenza. Nats, can we put it so that they're all up and we're not looking at one person?
I can't. That's what Carla did. I can't do that.
Okay.
Man, don't make me touch it again.
No, don't touch it. Okay, so true or false? Parents or carers are more likely to give their child an influenza vaccine if their healthcare provider recommends it. True. True. So research shows that basically parents or carers are 3 times more likely to receive influenza vaccination if their healthcare provider recommends it. Never assume. We get lots and lots of phone calls where we're talking about catch up with people and we chuck in and they're also eligible for influenza, and the number of providers that go, oh no, I'm not going to talk to them about that. Never assume that mum isn't going to have it or have a bar of it or come back in a week or whatever. Make sure that you're putting it out there as a normal vaccination for them to have. So this is something that we first started dealing with last year. So the emerging myth of trivalent versus quadrivalent vaccines. So the 4-strain shot must be better than the 3, especially when it's got that Brisbane one in it. You know that Brisbane one? That's the one I'm not getting now. So the facts around it are that the new trivalent formulations are specifically made to counter the flu subtypes against that age group. So they're specifically for the over 65s and what is circulating within that age group. The flu AB, so the trivalent one, improves the immune system response by providing greater, longer lasting protection. And the use of the improved trivalent formula reduces the risk of developing pneumonia when compared to the quadrivalent formulations. So it's a pretty interesting one. Okay, can somebody mute, or is someone else joined in?
This is Moynton Island. We've just joined in again. We had problems before.
Beautiful. Thank you.
Thank you.
So the 2019 seasonal influenza program, so everybody would have hopefully gotten the Chief Medical Officer's statement. It's available online or out the front, and we've circulated it within the emails as well. So this year more than 6 million doses have been secured to ensure Australians who are most at risk of getting sick are able to access free influenza vaccines. So that's 1.4 million doses more than last year. So that's pretty impressive. So annual vaccination is the most important measure to prevent serious illness, reduce the risk of death and related complications, reduce hospitalisations and ICU admissions. In this year's influenza virus, we've got 2 new strains. So we've still got the influenza A H1N1 Michigan. We have a new influenza A, so it's a Switzerland H3N2 virus. We have in the trivalent, it ends here, with the influenza B Phuket-like virus. Oh, thank you. And then in the quadrivalent, we also have the addition of the new Colorado 2017. Excuse me. So recommendations, annual influenza is recommended for people aged over 6 months. So all people it's recommended for, but it's not funded. So eligibility for funded vaccine now includes, and this is so worth celebrating, finally, all Aboriginal and or Torres Strait Islander people from 6 months of age. So that we've been fighting for years. There's no longer a gap between that 5 and 15-year-old age group, which is just fantastic. All adults aged 65 and over for the trivalent vaccine, Fluad. Medically at-risk people from 6 months of age, and that's as per the handbook and also on the back of the Queensland Health poster. Pregnant women at any stage of pregnancy, and in Queensland we fund it for all children 6 months to less than 5 years. So if you're reading stuff about national program information, it won't include that there, but the Queensland government funds it for all kids 6 months to 5 years. So vaccine delivery was to commence from April 1st, and I believe from what we've been hearing it has well and truly. Just be mindful, if you haven't received stocks yet, it actually takes 2 weeks to deliver to the whole of Queensland. So if you've already got it, you're kicking goals, and so are they down in the warehouse. Weekly ordering will commence from the 15th of April. Don't forget all the public holidays we've got going on, so deliveries might start to get delayed. And you can also order Pneumovax 23 and Zostavax weekly within this period.
Hello from Power Bank. Sorry to interrupt. I just got through.
Thank you, Michelle. Welcome.
Sorry, it came back so late.
Oh, well, that's okay. So we've got 5 different influenza vaccines on the NIP this year. We had 6 last year, so we're getting down 1. Making sure that you've got adequate storage space within your fridge, and really take advantage of that weekly ordering if you can, so that you can, make sure that you've got enough space and can turn over your stock. And please be mindful that age restrictions do apply. So this is just a breakdown of the program advice. So for 6 months to less than 3 years, we have the Flu Quadri Junior. So that's the vaccine to be used in that age group. For 3 to less than 5 years, we have the Flu Quadri or the Flurex Tetra. For 5 to 64-year-olds, we have the Flu Quadri, Flurex Tetra and a Fluria Quad. So a Fluria quad was the one last year that was only able to be used in 18 years and over. It's now come down to 5. So hopefully that makes it a little bit easier. And in the 65 years and over, we only have one vaccine on the NIP, and that is Fluad. Please don't use it for any other age range other than the 65 and over. As I was saying earlier, this poster is available A3 and also A4 with some more information on the back around medical at risk and things like that. So if you need some or you want the PDF, just flick us an email or yell and we'll try and get it out to you. There was an NCRS webinar that was a couple of weeks ago now that had this table, because everybody learns and is a bit different with visuals, but it might be helpful. It's got all the vaccines on the Australian market. So the 4 that are highlighted are on the NIP and then the Fluad as well. The NCRS webinar, in case anybody's missed it, is still available online to watch back. So if you'd like to do that, you can just go onto their website and follow through the prompts. Influenza Resources, these are ones from the Immunisation Program unit in Brisbane. They're the same ones as last year. We haven't seen any new stuff yet, and we're waiting for resources from the Commonwealth. The one that we quite like is this 5 reasons why children should get the flu shot, with some little prompts. They're just good little tips to be able to talk to parents with. So what are we waiting for? We're still waiting for the ATAGI statement. Hopefully that will be out shortly, and the Commonwealth resources, I don't know when they're going to be available. We thought they'd be out for us in February. So anybody else taking bets, ladies? No? With flu season and with this sort of stuff, we need to start thinking about vaccine management and fridge space. Please, 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 and this sounds really, really silly, but please make sure you don't have any influenza vaccines from last season. You know, it's all expired, but we've walked into practices and found vaccine in the fridge even a fortnight ago. So just please make sure you grab it all and get rid of it, because the boxes are very similar. You know, we've got busy practices. It's very easy just to grab and go. Don't overcrowd the vaccines by overfilling the shelves. Make sure your purpose-built fridges are maintained and serviced annually. Make sure you check your backup power supply and that you've got enough emergency equipment to store the vaccine contained in your fridge. Hello? No? That includes making sure that you have enough ESCIs and a maximum thermometer for each of your ESCIs. And check that your VMP, your vaccine management protocol, or your workplace instruction is up to date. So Immunisation Program unit in Brisbane is actually starting to crack down on this. So when you're placing orders, when you ring in about a cold chain breach, all those kinds of things, they might just start randomly asking you for your vaccine management protocol. So if you make sure that it's up to date and everything's ready to roll, it'll be really smooth and won't interrupt anything with your practice. Oh, and don't have this kind of fridge happening. That was a practice visit, wasn't it? A local practice visit. So true or false? A 3-year-old had 1 dose of influenza vaccine in 2018. This year they need 2 further doses 1 month apart to catch up. False. Correct. So the 2 doses a month apart is for the first year only, and it's about having the first dose to prime the immune system and then the second one to give them their longer lasting immunity. Subsequent doses from there are 1 dose annually, and we never catch that first year up until ATAGI releases something different in their statement next week. So true or false, I can half an influenza adult dose to make a paediatric dose. False. Beautiful. We cannot do that, and Flu Quadri Junior is the vaccine to be used in 6 months to 3 years of age. True or false, BCG and 6-month vaccine can be administered at the same time or without delay?
False.
It's actually true. Yeah. So BCG can be administered at the same time or at any time following receipt of other inactivated vaccines. So the only time we need to think about it is when we're doing our MMR or our varicella and things like that. There's no restrictions on the timing of BCG in relation to oral live vaccines, including rotavirus. So the NIP, where to from here? There's no planned changes to the Queensland schedule. But. We're very lucky, we're very fortunate. We've got a very proactive immunisation program in Queensland. So we have had Queensland Health funding for the meningococcal ACWY program for 15 to 19-year-olds. So that is a program change for most of the rest of Australia, but it's not for us in Queensland. All we get is the swap of the brand from Menactra to Nimenrix. So you'll start seeing less and less Menactra and more Nimenrix to use in that program. Other possibilities that we are thinking may happen and is now updated in the handbook is DTPA for pregnant women from 20 weeks gestation. So that recommendation is now within the handbook, but it hasn't yet been approved or signed off for the funded program. So this is just a heads up of something that may come in the pipeline in the not too distant future. Maternal vaccination program. So women are more likely to be vaccinated if their health provider specifically recommends it. So it'll be available through the NIP for women in each pregnancy, even if they're annually. And it's at the moment a single dose in the 3rd trimester, preferably 28 to 32 weeks. But as I said, the handbook has just been updated to say from 20 weeks. Seasonal influenza is a single dose at any time during the pregnancy, and vaccination of pregnant women with these vaccinations is safe and has the additional benefit of providing protection to the newborn. They can be given at the same visit if needed. ATAGI produced a clinical advice statement last year. It's a really good piece of work, so if you need a refresher, please go back and read it. This year, Adacel and Boostrix can be used for the program, and the antenatal diphtheria, tetanus, pertussis vaccination is primarily aimed at protecting the baby against pertussis. So we often receive a lot of questions within the unit around why it's not funded for fathers, why it's not funded for grandparents, all that kind of stuff. It's because there's only so much money in the bucket, and this is going to give us the most bang for buck because it protects mum and it gives the newborn protection for the first few months of life. So vaccination during pregnancy is shown to reduce pertussis disease in infants under 3 months of age by 91%. The transfer of maternal antibodies across the placenta during pregnancy is during pregnancy, and the highest levels of infant pertussis antibodies are achieved when vaccination occurs early in the 3rd trimester. Vaccination shouldn't be delayed until closer to the birth because pertussis antibodies peak 2 weeks after vaccination, and some women deliver before they reach term. Antenatal influenza vaccination is recommended to protect both the mother and the baby from influenza and its complications. And vaccination during pregnancy is estimated to reduce the risk of influenza in infants aged 6 months by about half. And infants born to mothers who contract influenza during pregnancy are at higher risk of preterm birth and low birth weight. Pregnant women are at higher risk of complications from influenza and twice as likely to require hospitalisation. And there is no evidence of increased adverse pregnancy outcomes related to the DTPA vaccine or influenza vaccine during pregnancy. Immunise Australia have got this beautiful Brolga resource available, and you can order them online and get them mailed directly to you if you would like some. They've got some pamphlets and things like that as well. Medically at risk babies. So it's important to recognise that some babies are eligible for additionally funded vaccines. So low birth weight bubs, less than 2,000 grams, and or infants born at less than 32 weeks gestation are eligible for additional paediatric Hep B at 12 months of age. All preterm infants born at less than 28 weeks are recommended to have a Prevnar at 6 months with a single booster of Pneumovax 23 at 4 years. The big thing to flag with everybody is now we don't have virus, so we no longer have the ability to document these babies anymore or register them as medical at risk. So we're hoping that you guys can start to look at some systems and things that allow you to flag those babies as requiring the additional vaccines when they come in as your clients and things like that. Something else to flag is our Indigenous clients at 6 months. They are also due to receive a Prevnar 13. AIR, however, doesn't flag it as due. Because it's not the standard schedule, it's considered a different schedule. It will not actually remind you that Prevnar 13 is due at 6 months of age. So it's really important to be mindful if your client's Indigenous to make sure that you're looking at the additional vaccines they require. Older adult immunisations, so Pneumovax 23 is recommended at 65 years of age in non-Indigenous and 50 years of age in Aboriginal and Torres Strait Islander adults. You can refer to the online handbook for further eligibility criteria, or we've got our tip sheet that you probably know and have used in the past, and they're available. Zostavax is recommended at 70 years of age, and it's still available for catch-up for the next few years, up to 79. And yeah. This month, so the 24th to the 30th of April is actually World Health Immunisation Week. So if you do any displays or setups or anything like that, this could be a good one to use for a bit of health education and promotion. So the end of the month. The resources that are around, of course, there's the immunisation handbook. There's Sky, which is actually a really good parent resource if nobody's had a look at that yet. So sharing knowledge about immunisation. It's got some great little videos, pictorials, fact sheets and things like that there. NCRS, of course, their influenza information and FAQs is really good this year. And there's the immunisation program updates, which come out fairly frequently. For those of you that are wanting something more specific to immunisation, we have a free online immunisation education course. So that's available for Q Health and non-Q Health staff. And it also covers both clinical and non-clinical, so admin and things like that are able to access it and click on the course that's specific to their stream and go through and do some modules and things like that. So there's vaccine administration, vaccine management, so cold chain, immunisation data, recording and reporting, and then catch-up vaccination. So this is free and available online, and will actually give you RPL for the authorisation courses within Queensland. So, does anybody have any questions in the room or online?
So the influenza vaccine can be given at any stage during pregnancy. So if you gave it in the very early stage, influenza vaccine normally lasts, is it 4 to 6 months in its effectiveness? Is that an issue? With, you know, the mother getting protection as well as then the baby at birth?
Yeah, I don't actually know. I haven't seen any of the other, I haven't seen any information come out around that. I think it's really a clinical question, and we would refer it to Richard really, and then, you know, other physicians would probably have different opinions on it. So.
It's whether to delay giving it.
Yeah.
To whether to delay giving it. So
I know that Richard would not say to delay.
No, yeah, I understand that.
Yeah.
Want the baby to have some protection when it's born.
Yeah. Well, you know, it's 6 of one, half a dozen of the other. You know, we want to make sure that the mum's good and protected too, because they're at the higher risk of a whole heap of different complications and that impacts on bub then. So that would be one that I'd phone a friend on.
Anyone else?
Is the staff vaccination going to be the quadrivalent or the trivalent?
Depends on your age group. So
you've got to stock
if
both.
you are over 65, it will be the trivalent. If you are under 65, it will be the quadrivalent. Any others? Anybody online? And I'm going to pass the baton on to Kathy. All good? You know that you can ring and chat to us. Fabulous. Thank you. Where are you? Okay.
Don't you get rid of my phone.
Don't you delete them again.
Oh, no, I'm not doing that.
You're clipping that on and you're turning that on. Purpose. You did, you know.
Right there.
Enjoy.
And what is this?
That's the battery pack. I don't know, I just hung it here.
Can you use an arrow keys?
I just use it else.
Oh, okay, cool.
Thank you.
Good evening, I'm Kathy Lord-Phillips, and for those of you that don't know me, I'm the Immunisation Data Officer for Tropical Public Health, and it's my job to maintain the air register, basically to ensure that the data is good, of good quality, and the challenges are getting greater and greater because there are more people now entering their own data. So that certainly keeps me in a job. And so tonight, one sec, go. What is going on next? Okay, here we go. All right, so the topics I'm going to talk about tonight is I'm just going to give for those newcomers a little background, not a long background at all, of virus and air. We're going to talk about recording dose numbers because that seems to be the biggest issue of errors that we have on the register these days. Also about reporting other immunisation related info, using the secure email and where you can get help. I'm not going to do any demonstrations at all, but I do have some screenshots of literally A to Z of the air register in the back and amongst other stuff. Okay, so the commencement of Vivas and air, just hang on a sec, commenced in 1996. Initially, it was a register for 0 to 7-year-olds. At the same time, Queensland Health felt that they needed to be able to record adolescents and adult data. So hence Vivas was also commenced. In 2016, AIR decided to become a whole-of-life register. And it was at this time that Vivas decided there's just no point in having 2 registers. So they started the transition to really cease collecting. So it's been about a 2-year transition. And finally, as of 3 days ago actually, Vivas now don't collect data at all. The only data that they are still collecting is the school-based data. However, and that is only until the end of the year. It is still, people are still encouraged to start entering that data onto AIR as well. Okay. The only paper for records of anything that should be going into Vivas now should be the Hep B serology forms that are done in maternity. So besides that, there should actually be no data records at all going into Vivas. They're not actually going to be recording that data, but I think they're going to keep those records of the serologies. So what about moving forward with Vivas from now on? It still will exist. It does still exist. So it's a register that we can still access, and we can still access the historical data. But basically it's going to be an administration system, so it will be managing the dispatching and ordering of vaccines and cold chain management. And that's basically it. The changes to AIR, and I'm sure you're all aware, those of you that are using AIR from 2016 to 2019 have been enormous. The register has just gone from quite an antiquated database to quite a lot more sophisticated and much more user-friendly. So just to mention a few of the changes, the register now has enhanced identity matching. So if you put a name in and you don't know the exact name, it'll actually pick it out from similar spelling. As a VSP, you're now able to add natural immunity or medical contraindication to a record. You also have the allowance now to print a history statement, and that in itself is a much more user-friendly reading material to see the antigen versus the vaccine brand. Anyone with a Medicare card over the age of 14 can now register with MyGov, which I'm sure you're all aware, and they can view their own history statements on the register. And of course, their parents are able to do for children under the age of 14. There's also now allowance for you to enter the HPV vaccines onto AIR, and AIR is routinely recording those. They've also included the school names on the register, and there's also now provision for batch numbers to be recorded. AIR does not necessarily use these batch numbers for anything, but they're there as a reference for your clinics. You can also now make an alert on the register for a child that's on a catch-up. So you can just tick the box, and that'll prevent the Centrelink payments from being cut off for those children. So what changes are to come? By the end of 2019, AIR is hoping to have all historical data transferred over from Vivas, which will actually make your lives a lot easier, and you'll be able to view all adolescent and adult data as well as children's data. It will only be data post or vaccinations post 1996 because that was when the register commenced. Okay. Sorry. Oh, hang on. How do I go back here? Oh, Nancy, I need to go back. Okay. Sorry, guys. There we go. Okay, so for those of you who are not that familiar with the AIR screen, I'm just going to show you this one. So to the left, you've got your main menu, where you can choose whatever section it is that you want to identify a record, and the main content of the details of the person goes into the main content there. I'm going to use that mouse. Okay, so reporting the data to AIR. So basically there are three ways: practice management software, GP practices, and you can access AIR directly through the HPOS online service. There's also the paper record form that is available. However, we're strongly encouraging you not to use this paper form. If you were to, and you mail it into AIR, you're probably going to wait 3 to 4 weeks to get that data on. So it's probably quicker for you just to use the register yourselves. So what are the vaccinations that are actually being reported to AIR? Is all immunisations in the National Immunisation Program schedule. So that's including adults for pneumococcal and zoster. Vaccines given through the school programs, and vaccines given privately, flu and travel vaccines, and overseas history data, any historical data post to 1996. And just for the record, AIR is not recording Q fever or rabies immunoglobulin. Okay. So the one thing that I really want to touch on tonight is dose numbering. So when you're entering your own data onto AIR, whether it be in your software or doing it directly, I would just ask that you just be very, very mindful of what the history is already there. So to check the record, because the dose numbers is actually vital. If we get the dose numbers wrong, it's, the child's obviously running risk of being over-immunised. So the ACT HIB at 18 months, the child would have had the 2, 4 and 6 months hexa. So that has to be recorded as a dose 4. Then the Hep B at birth, if you're doing that in the hospital, then we'd ask you to record that as birth dose and not dose 1. And initially we were suggesting that in the hospitals, in maternity, that you actually create a baby of record on AIR. We're now suggesting that that's actually for you not to do that because it's actually becoming a bit of a problem. We're finding there's a lot of different variations of putting the word baby in, so it could be baby of, or it could be BO or B/O, so it's just creating actually more errors than anything. So what we suggest you do is just to put it in the red book and ask the parents to present that for the first 2 months with the red book, and then we're asking everybody else who is giving that 2 months to please enter that data onto AIR, just that Hep B for us, and that would be fantastic. Save a lot of problems. 9 times out of 10, by the time that child presents for the 6 weeks, 2 months EMS, they will be on the register. The MMRV given at 18 months, they would have had an MMR at 12 months, and providing they've had that, then obviously that's going to have to be a dose 2, not a dose 1. Infant Rex at 18 months, probably the biggest problem that we're finding on AIR is that this is recorded quite often as dose 1, possibly because they've had Infant Rex hexa. and not an Influenza on its own. So just be mindful of that. So they've had 2, 4 and 6 months of Influenza in the Influenza hexa, and this should be recorded as dose 4. And then obviously at 4 years, the Influenza IPV, providing they've had all of the above, 2, 4, 6 months and the 18 months, then that would be a dose 5. Okay. Then influenza is the next thing in children, then that is just sequential. So, reporting other immunisation-related info, personal detail changes, you cannot, I cannot, and you cannot change anything that is personal related to anybody. That will have to be up to them to go to Medicare and have that changed, and that is then automatically synced onto the register. So that would include date of birth changes. For example, we might have it might be wrong on the register, any address changes, Indigenous status, and Medicare number details if they've changed. Natural immunity and medical contraindication, as I mentioned before, you're actually able to now enter that yourself onto air. And you can advise air of any individual moving overseas, and they will actually inactivate that record, so you won't be able to see that child's record, and the overdue reminder letters will stop going to that address. Deceased individuals, whilst the births registers, deaths and marriages registers will actually notify air, it takes anything up to 10 weeks. So by that time, it's quite, I guess parents could very well have received an overdue letter. So if you know of a child or, that has deceased, it would probably be great if you could let air know, and they will accept that as well prior to being notified officially. Duplicate vaccination entries on air. So if you come across any whilst you're looking at them, you can also let them know, and they will merge those records for you. Any Medicare-related details, that again it falls under the personal detail changes, so you won't be able to change those. They'll have to go to Medicare and change that themselves. And you're obviously now also able to tick the box to say that an individual is on a catch-up schedule. So there's only ever one opportunity to have them on a catch-up schedule, and they have to be caught up within 6 months. So for those of you who are not very familiar with the secure email, this is actually a really good and useful tool on air now. The purpose and the functions for the secure email is there really to notify air of any data changes, but as I mentioned before, not anything personal. You can't notify them about Medicare number changes or gender or ethnicity or anything like that. So basically what you can notify them is any request to amendments regarding data errors or anything like that. And by the way, they will probably respond to you within about anything up to 4 or 5 days max. So their turnaround's pretty quick. You can notify them of any duplicates for merging. You can notify them of any individuals relocating overseas, and they will obviously then stop sending reminder letters, and deceased individuals. Partially processed data error codes, probably the most that I use the email for. The one thing you cannot do is to ask them to, get them to enter data via the secure email. That is something that you are required to do yourself. So I just want to go through, that's basically what the email box looks like. So you've got your new email box there. You can file your mail once you've read it. It's really quite user-friendly. So I just want to touch on the partially processed pending error codes. So what is actually meant by this? When data is entered correctly, AIR will record it as accepted. But if it's incorrect and it's outside of the schedule or it's the dose number is incorrect, it actually won't accept it. It will remain there, but it will be noted as partially processed, and there'll be a little pending error code. There are hundreds of error codes, so what you would need to do is just hover your little mouse over that error code and it'll tell you what that error is. And when looking up an immunisation history, I'd recommend that you actually look at the immunisation history and not the immunisation history statement. And the reason for that is if you have one of these partially processed error codes there, AIR actually hasn't accepted that as a valid dose. So that when you actually print that history statement, it's not going to actually appear on that history statement. And I'll just show you an example. If I can find this little thing working. Okay, so this is the partially processed error that I was talking about. For example, this child has had his 2, 4 and 6 months, so the hexes are all there, and then it's had this ACT-HIB, and as you can see here, they've called it a dose 1, which in fact it should be dose 4. So it's only been partially processed, it hasn't been accepted, and this is your error code here. And if you hover your mouse on that, that'll tell you that that's actually a duplicate antigen dose because it's had an Influenza Hexa 1 already. All right? So basically, I printed this off the other day and I checked that and I printed the history statement at the same time. And if you have a look, you won't see that it's had an ACT-HIB. So it's actually not a true picture of what this child has actually had. So I would just suggest that if you have checked and everything is fine and everything's been accepted, then it's okay to print these off and give those to your clients. Okay. So I'll just give you an example of this child's born on the 7th of June, 17. Immunisations to date include 2, 4, 6 months given at the scheduled times. 12 months is given on time, 18 months is given on time. But AIR is still reporting that this child is overdue for a DTPA and a prior ex-tetra. So, again, this is just, again, all to do with recording. So the 2, 4, 6 months are all there, they've been accepted, and they're all within the scheduled times. But the 18 months here, given on the 9th of January, are recorded as dose 1 Inforex, dose 1 ProQuad. And so they partially processed. The error code here says that this is a duplicate antigen dose, and AIR is saying that this kid is still overdue for a DTPA4 because it hasn't seen one, hasn't recognised that there is one. And the same goes with the ProQuad. So if we're not careful and check these, accurately, obviously the kid runs a risk of being over-immunised.
How do you fix that?
Okay, so we're going to get to that. So basically this is where we use a secure email and we advise AIR to change the dose numbers. Unfortunately, we are able to put data in, but we're unable to edit data on AIR, which is actually a real shame because it actually doesn't make sense to me at all that we should be able to be putting data in, but we can't change it. But that's just the way it is with AIR. So using the secure email, this is where you would actually need to go in and give them all the child's details and say, look, these two here, these two are incorrect. Can you please change them to dose 4 and dose 2, and that will automatically fall away. I've got some screenshots outside, and it's literally, they're very user-friendly, and they're literally from A to Z of using air and sending secure emails, etc. So please help yourselves. And there's another example here. It's pretty similar. This kid has had everything up to age 5, and its air is saying, or up to 4, the 4th birthday, air is saying the child is overdue for a DTP 5 and polio dose 4. And again, we've got the same issue here. The infant Rex IPV should be dose 5. He's actually had 4 infant Rex, and so that should be dose 5. And it's saying that this child is overdue, and it's needing a 5th dose. Okay. At the same time, you can see the Menactra is recorded as dose 1, so that's also partially processed because it doesn't. It's had a Menitrex here, dose 1. So this should actually be dose 2. And again, all we'll have to do is just notify air, and within 2 or 3 days, it'll be fixed. And this is just about transcribing data from overseas history forms. So it's just an example to show how misinterpretation and incorrect transcribing can cause a child to be overdue for the wrong immunisations. This record was actually, the data was put in by a local service provider. I'll look here, I'll come stand here so I can see what I'm doing. So AIR is actually saying that they require a measles, mumps, rubella, a meningococcal, a varicella, and a DTP. But if you have a look here, the Hep B, can you all see? The Hep B birth dose, that's fine. That's a B, so that's birth, it's okay. So then suddenly the second Hep B, they've called it a dose 2. That actually should be a dose 1. And then on the 8th of June, the dose 3 should be a dose 2. But if you have a look at these intervals, from the 8th of June to the 29th of July, it's not 2 months. There isn't a 2-month gap between the second and the third dose. So they've kind of missed that. And then, of course, the DTPA 5 should be a dose 4 because he's only had 3. So, in fact, he doesn't need a 4th one. And this should be a dose 5. So, you know, and that was actually just from transcribing. So, yes, he did definitely need the measles, mumps, rubella and the meningococcal, but he also needs another Hep B. So it's just, I guess the message is just saying it's very, very important to be mindful of the dose numbers. Oops. Okay. All right. Record encounters you can actually create a record for a person who doesn't have a Medicare number, and there are lots of records on air where people don't have, are not registered with Medicare. So that's not a problem. Again, I'm not going to go through how you do that because it's all in those screenshots that I've got out in the front. Just be mindful that AIR recognises the national due and overdue rules for immunisations for the NIP schedule, but it doesn't recognise the ATSI schedule in Queensland. So when you're reading what a child is overdue for, be mindful if they're Indigenous, then obviously it won't be on the record, and you'll have to remember what the ATSI schedule is, obviously. If anybody here is interested in me coming to your practice and giving you a one-on-one air demo, I'm very, very happy to do that. It's what I do. So please, there's a sheet out front, and you can just put your name, details down, and I will make an appointment to come and see you. And I've got some handouts, and there's some air screenshots in the front. There's also a dose number guide, which could be very handy for you to keep in your practice, and where to get help. Thank you. Any questions? Okay. Okay.
I have them turned off.
Does it work?
Oh, as in
From anyone remote.
Oh.
They might have a question.
Oh.
Is there a question?
Are there any questions?
It's not. Oh, it is working.
Yes?
I was going to say I phoned a friend and I have the answer to the question. I'll pass the microphone back to Di in a second.
My question is about those babies at 6 weeks of age who haven't actually, their registration for Medicare hasn't come through. Are they counted as someone that hasn't got Medicare?
Yeah, so I can't hear you very well, but the Medicare, they haven't got their Medicare numbers yet?
Yes. So not, when you search for them on air, you cannot find them?
Yes. So that is why...
Baby of,
Sorry?
You're saying you don't want them put in as baby of?
No, well, we probably don't. The only time we'd say yes, it's okay, but if they've, basically at 6 weeks old, are you from a practice or are you?
Community health.
Yeah,
We see it quite
okay.
often.
Yeah, so by that stage, the parents have named their child, we would assume, and we're very happy for you to create a record in the child's given name. So providing it's exactly as they are going to register that child on Medicare. Because what you've got to imagine is that once they register, they've got to sync those two records. So if a parent are 100% yep, they're going to register that child under that name, not a problem. And then you make sure that the address is correct, etc., and it'll merge. Yeah. So if you can, I mean, we just want to make it as easy as possible. And I know that some children at the age of 6 weeks don't have their Medicare registration. Any other questions? Any questions online? No? Okay, thanks very much. There's your pointer. You don't want it? Okay. That's the back of it, eh?
Okay, so I have Di that can answer, is going to be my phone a friend for the influenza in pregnancy question earlier.
Okay, so the question was that if we're going to if we're going to give the vaccine earlier in pregnancy, that it would only last for 4 to 6 months, and so was it any use giving it earlier? The fact is the vaccine doesn't only last for 4 to 6 months. The efficacy and the length of potency of the vaccine or the stimulus in the client is not really measurable, but the antibodies that they have measured, they get the best response in the first 4 to 6 months. So it doesn't stop suddenly working at 6 months. Some people get quite a good effect from the vaccine longer than that. So looking at the risk of the pregnancy that may happen, the delivery may happen preterm, then even if they do choose 20 weeks as a time to give the vaccine, you'll still get quite a good response from that. So the vaccine doesn't stop working at 4 to 6 months. You just get a much better efficacy in those first 4 to 6 months. But it does continue to produce sustainable antibodies after that 4 to 6 months. So it's a matter of looking at the risk to an earlier child or an earlier delivery overall. But you're still going to get some response after that 6 months. Does that make sense?
Thanks, Di.
Am I on?
Yep.
Hi everyone, I'm Carly. I'm one of the communicable disease control nurses. So Julia Esmond is usually here, but she's away at the moment, so we've got Di filling in. I'm going to be really quick because I know everyone's tired and wants to go home. I just want to give you a quick update of what's going on with communicable diseases at the moment. So who are we? We respond to notifiable conditions as prescribed by the Public Health Regulations 2018 under the Public Health Act. We've got a statewide notification system called NOx, which basically any pathology that fits a certain criteria, that gets fed into that system and then we get to see it on our screen. We respond to outbreaks in communities and facilities, and we provide ongoing surveillance of communicable diseases within CHHHS, which you guys are an intricate part of that surveillance system. So you guys are on the ground, you know, you're seeing what's walking through your front door. And we're a resource for health professionals, organisations and the public. So basically this is the Schedule 1 notifiable conditions. So last year the public health regulations were updated, and the biggest thing was that rheumatic heart disease became a notifiable condition. So basically we have some conditions that are notified on positive pathology. So those kind of include Ross River, influenza, pneumococcal or Shigella. A lot of that stuff we don't see. It's sort of background reporting, so we don't actually visibly see it on our screen. That includes influenza. So for us, it's important if you guys are seeing someone that's got a positive result and you know they're from a nursing home, for instance, that's something that we want to know about. We also get reported on clinical and provisional diagnosis, so that would include ARF or Hib or tetanus. And then there's the ones that we want to hear straight away when someone's in your surgery, because we need to instigate a public health response immediately. So those would, of course, include things like dengue, gastro in a food handler, ABL exposure, measles or meningococcal disease. So what vaccine preventable diseases are we seeing in CHHHS? So we know last year we had a lot of pertussis. So these figures are published figures from last week, so we're a week in again, but they hadn't come out today. So so far we're still seeing a bit of pertussis, 17 cases, but we had 50 last year this time. Mumps, you know, we've had a pretty big year with mumps last year. We've only had 1 case so far, 82 cases for the same time last year. Varicella, same. That's something that's constantly circulating. So 105 so far, 108 last year. What we are seeing a lot of, which Romany's already alluded to, is influenza. So the published data from last week was 712 labbed confirmed cases. Same time last year, 200. So these are lab confirmed cases, so you can imagine this is not the whole burden of disease in the community. These are the only the people that are actually getting tested. And if you look at the diagram around that green ring, that's the peak that we're experiencing at the moment. So like Rom said, we typically have 2 peaks, that kind of winter peak and late summer peak. And as you can see, our late summer peak around that number 11 is a lot higher than it has been for previous years. So what are we seeing globally? The big one, of course, is measles that I want to quickly talk about today. So last year we had over 324,000 measles cases that were reported globally. So you're talking about countries that actually have a surveillance system in the first place that can report this. So that would be the tip of the iceberg. That was nearly a 50% increase from the year before, killing around 136,000 people, despite the availability of a safe and effective vaccine. 10 countries were responsible for 3/4 of that global surge, including France. And in the USA, they had a nearly 600% year-on-year increase in cases. Currently, they have one of the counties in New York has put out a public health emergency. They've basically banned any babies or teenagers from going out in public that haven't been vaccinated against MMR because they're having ongoing transmission. I think they've had about 140 odd cases. So what's driving this? Conflict, complacency and the anti-vax movement. So as you can see, this is some published data from WHO. So the square there is what we've been seeing last year, and the others are previous years, if you can read that there, but you can see there's a significant increase. So this is our top 10 countries. We're an international destination, and we have a lot of people travelling in and a lot of people travelling out. So if you look at some of the top 10 countries, we're talking about Thailand, Brazil, Philippines, India, countries where we would have regular travellers to. So part of your pre-travel screening for any of your patients would be around MMR. It's safe, and for the majority of us, it's free. So measles in Australia, so far we've had 9 cases this year to date. 1 confirmed case last week in Townsville. Also, New South Wales, they've just reported 2 cases in a bub that was 8 months old and one that was 11 months old that were locally acquired. So that one confirmed case in Townsville is from a current outbreak in the Northern Territory where they've had 23 cases in total. So the majority of those, 22, were locally acquired. It was just one import initially that sparked that. So Darwin and Palmerston currently are actually vaccinating their bubs at 9 months. So what's the moral of this story? Herd immunity. It is incredibly important. So if you're unsure of someone's history, please check with us. If you're unsure, nothing's documented. If they're able to have it as a funded vaccine, just give it to them. Of course, I can't not talk about bats. So last year we had 71 bat exposures. 31 of those were during the heat wave. We spent over $100,000 on post-exposure prophylaxis in about a month. We've had about 13 this year, but it's ongoing. So, of course, it's important to remember in our unvaccinated, any exposure that breaks the skin, bite or scratch, even if it's superficial, requires immunoglobulin and 4 rabies vaccines. That immunoglobulin is positioned in the hospital here. We are able to get it up overnight from Brisbane, but then it becomes a problem if it's a Friday and we can't get it up over the weekend and whatnot. So often it's best to come to hospital. Except when ED's in a code yellow, which is every day. So for those that have been previously vaccinated, they need 2 booster vaccines after every exposure. So who doesn't recognise a safe titer level? There is no safe titer level. I say it again, there is no safe titer level. And regardless of when you were last vaccinated, you need to have 2 booster doses after every exposure. So what are our usual suspects? So melioidosis, which is a bacteria that's found in soil, we often have an increase in cases after heavy rain or earthworks. So recently, after the floods in Townsville, they've had 20 cases. Risk factors include chronic disease and excessive alcohol use, and it always requires hospitalisation and long-term IVABs. Most of the time, a lot of that's done as hospital in the home. So leptospirosis, which is Di's favourite. Personal favourite. That's a zoonotic disease that's usually associated with occupations such as banana workers or recreational activities. We know that disease very well here. Innisfail has a stamp that says clinical lepto and all the appropriate tests. However, in other places around the world, that's not a common disease. So in May, we have a 2019 World Water Rafting Championships in Tully. So we're getting people coming in from all over the country. So we're working at getting some health promotion messages into the competitors when they're here. Dengue, we've had a very successful Wolbachia program that's been released in basically all our suburbs, and we're yet to have a dengue outbreak since then. The last one we had was up in Mareeba, of all places. So we continue to see imports. We've had 10 this year. Of course, usual suspects, Bali, Philippines. So if you're getting anyone that's got suspected dengue, please give us a call or use those fax forms that everyone should have. I just wanted to briefly talk about Group A strep. So if it's found in a sterile site, and so it's an invasive case, it's notifiable. So we get notified and we'll follow up with those cases. However, it's always circulating and it's causing some devastating effects to our most vulnerable populations. We know a lot about ARF, which can affect your heart, but we're also seeing a lot of acute post-streptococcal glomerulonephritis. So APSGN, it's basically an inflammatory disease of the kidneys, which usually occurs about 2 to 3 weeks after you've had usually skin sores or a sore throat, but it's a particular type of gas that needs to be circulating. It's not a notifiable condition, but we want you to let us know. So if you're seeing kids in clinic that have got some old sores, they're looking puffy, they're hypertensive, we want to know about those kids. So we've had recent cases. We've had 3 cases up in Mareeba that were linked to the NPA. We've had 3 cases in Yarrabah that were deemed to be linked cases. Therefore, we had to do a community-wide response. We screened every child between 1 and 17. Anyone with skin sores got sent to clinic and had some IM Ben-Pen. So you can imagine that was pretty traumatic for the community. It was traumatic for the kids. It was traumatic for the staff. But, you know, the early on reports suggested about 50% of the kids had skin sores. So we know it's an issue. We recognise it's an issue. We've been really working hard around a surveillance system. How do we quantify that? But it's really difficult. So that's a work in progress. We've also seen it in urban Cairns. So we had 10 cases last year. Basically, we know within urban Cairns there's pockets of great disadvantage, and we've worked really hard to map those and to get them classified pretty much as a community themselves. So if we're seeing a couple of cases in that community, by our definition of our guidelines, we can go in and do a community-wide response. So what are we talking about that you might see before we get to that point? Infected scabies, school sores, infected bites or other infected sores following injury. So just to be really alert around those things. So don't forget to phone us. And this is the CDC guidance. It's actually on QEPS. It's pretty much our Bible. This is what we refer to when you ring us up and go, I've got a pertussis in a pregnant mother. So these are the guidelines we go to. You can access them online. And that's it. Short, sharp. Any questions? No, you can go home. Don't forget to do your evaluation.